si os parece, ¿no? Vale, bueno, yo creo que sí. Pues nada, en primer lugar, daros la bienvenida en nombre de la Fundación ALPE. Para los que no hayáis asistido a todo tipo de charlas o no me conozcáis, yo soy Susana Noval, soy la coordinadora de la Fundación. Con nosotros también nos acompaña todo el equipo de la Fundación, unos se ven, otros no se ven, porque el formato es seminario, pero con nosotros está Carmen Alonso, que es la directora de la Fundación, Estefanía González, que es la directora de proyectos, y Sonia Sestelo, que es la encargada de todo el tema de administración. Cuando apagamos cámara y veis MBA, More Empower in Your Hands, es que tenemos una colaboración con la empresa MBA, que es la que permite tener esta plataforma para poder organizar este tipo de seminarios. MBA es una empresa nacional y multinacional, ¿no?, que se dedica a, bueno, tiene todo el tema de ortopedia, de fijadores, de material quirúrgico, de material clínico, médico, y realmente son unos grandes colaboradores de la Fundación y nos apoyan en muchos proyectos y este es uno de ellos, ¿no? Entonces, cuando veis que a lo mejor se cierra la cámara y aparece MBA, es porque realmente MBA colabora y es partícipe para poder llevar a cabo este tipo de seminarios, porque todo suma, ¿no? Bienvenidos a una nueva charla dentro de lo que es el ciclo de expertos ADE. Para los que no estéis muy familiarizados con este término, ADE es un acrónimo que llevamos utilizando durante casi más de un año para abarcar la acondroplasia y otras displasias esqueléticas que causan enanismo. Un poco las siglas pertenecen a estos términos. Primero porque no queríamos dejarnos ninguna displasia que cause enanismo dentro de cuando hablamos de ellas o cuando nos referimos a ellas. Y segundo porque así evitamos muchas veces una connotación en estos términos a veces peyorativos con los que se utiliza la palabra enanismo, ¿no? Dependiendo de cada país, dependiendo de cada cultura, dependiendo de cada vocabulario, a veces nos encontramos con esta problemática. Entonces nosotras desde la Fundación decidimos de manera oficiosa, que no oficial, utilizar este acrónimo, las ADE, ¿no? Creemos que no nos dejamos en ninguna displasia esquelética y creemos que es una manera de utilizar este término para marcar dentro de esta palabra a todas las personas con alguna displasia esquelética que causa enanismo. Bien, pues dentro de este ciclo de expertos ADE, nos hemos propuesto organizar diferentes charlas con diferentes temas que creemos que son importantes en este objetivo principal, que es la divulgación del conocimiento, las buenas prácticas y el manejo de las displasias esqueléticas. ¿Por qué? Bueno, porque estas displasias esqueléticas están enmarcadas dentro de lo que denominamos a veces enfermedades raras, que no nos gusta mucho esta terminología, pero es verdad que se utiliza, ¿no? Siempre nos gusta hablar de condiciones poco frecuentes, pero bueno, es así. Y claro, como enfermedad rara o como condición poco frecuente, nos encontramos muchas veces que o bien hay poca información, porque se trata de una enfermedad rara, o bien la poca información que hay a veces es poco accesible por parte de los afectados y sus familias y poco accesible a veces por parte de los profesionales que trabajan con ellas. Entonces nos hemos propuesto intentar, ¿no?, divulgar ese conocimiento, el conocimiento que hay en diferentes áreas, divulgarlo, hacerlo accesible y hacerlo llegar a todas las partes interesadas. Siempre desde una perspectiva integral, que es cómo trabaja la Fundación ALPE. Integral, ¿por qué? Pues porque no nos quedamos solo dentro de un área. Es importante el área clínica, evidentemente, pero también es importante el área de investigación, que hemos tenido alguna charla referente a ello. Es importante el área educativa, es importante el área de los derechos sociales y derechos humanos. La perspectiva integral es fundamental para el buen desarrollo de la persona y su entorno, ¿no? La persona afectada y todo su entorno, su familia, sus amigos, todo lo que conlleva la sociedad. Para hoy, ¿qué tenemos? Una nueva charla del doctor Huser. Él ya ha estado con nosotros, yo creo que ha sido de los primeros, lo cual a nosotros nos hace estar muy felices. ¿Por qué? Porque sentimos que no estamos solos, que tenemos un gran equipo que colabora con la organización y que está a disposición, ¿no?, de lo que los médicos llaman pacientes, que nosotros siempre llamamos personas o familias, pero que son accesibles a su trabajo, son accesibles a su experiencia y evidentemente no se lo quedan para ellos, sino que intentan, lo que intentamos con este ciclo, divulgar y hacer llegar su conocimiento a todas las personas interesadas, ¿no? Compañías que trabajan con las displasias, familias, personas afectadas, niños, amigos, bueno, en fin, todo lo que conlleva la sociedad en la que vivimos, al fin y al cabo, que es de lo que se trata. Primero, bueno, pues nos habló un poco de lo que era el tema de traumatología en su primera charla a nivel general, y hoy nos va a hablar más en concreto de lo que es la cirugía de elongación. Él es un cirujano ortopédico que forma parte del equipo en el Instituto Paley, del doctor Paley. Evidentemente, nada tiene que decir, ¿no? Es un referente a nivel mundial en cirugía reconstructiva y en cirugía de elongación, y bueno, pues no encontrábamos nadie mejor para poder hablarnos y alojar un poquito de luz en estas dudas que llevan en este proceso, porque la cirugía de elongación a lo largo de la vida forma parte, ¿no?, de alguna de las fases. Es verdad que es una elección, a veces es necesaria, a veces es una elección particular, pero por una parte o por otra, lo que debemos es de estar informados, ¿no? Bien sea por necesidad, bien sea por elección personal, en España o en cualquier otro país del mundo, porque evidentemente los asistentes a estas charlas afortunadamente pertenecen a diferentes partes del mundo, pero bien parte por elección personal o bien por necesidad. Lo que es importante es tener la información, estar informados para luego poder tener una buena decisión al respecto. El doctor Huser creo que alojará un poquito de luz, un poquito de información, ¿no?, a lo que muchas dudas de las familias se plantean cuando llega ese momento, y estamos felices, estamos encantadas de poder estar con él, y no solamente estar con él, sino ofreceros toda su experiencia, todo su conocimiento. Así que, doctor Huser, gracias por estar otra vez con nosotros y con todas las personas que asisten a estos seminarios. Gracias infinitas por estar ahí, por estar siempre tan cerca de las personas que le necesitan, y cuando quiera, somos todo oídos, somos todo, ¿no? Estamos totalmente disponibles para todo lo que nos quiera contar.
So thank you again to the ELPE Foundation for having me. I really enjoyed last time and all the discussion. I think you said it best when you said, you know, lengthening to me is really a personal choice, and I'll get into that in just a sec. But so I have no disclosures, but I really think lengthening is a personal choice that, you know, we deal with a lot of children. They need to be involved in that decision making. And each individual should look at this and say, is this the right thing for me? I don't think anyone else can tell you, you know what, you should be lengthened. Or on the opposite of that, I don't think people should tell you, hey, you shouldn't be lengthened. It's really up to you if you want that. My partner asked me to not forget to remind everybody, especially patients with achondroplasia, that it's important before you undergo any surgery, whether it's deformity correction or lengthening, we need to consider the spine. And this patient had a kyphotic segment, which I've circled here, and ended up with a fusion, which is also somewhat controversial in that, is fusion the right answer versus decompression? I'm not the one to answer that. We do choose fusion, as we've seen some people who get decompression and then go on to require yet another surgery for fusion. But when you do get fused, your back does become stiffer. And so those are all important aspects of this treatment that you need to know about. However, the point for today's talk is that prior to lengthening, you should be evaluated for spinal stenosis, because we've had cases where patients are undergoing lengthening and all of a sudden they aren't able to lift up their foot, and usually it's due to the stenosis in their back. So what height is the world made for? I think that's a question that should be answered if you're considering lengthening. I was measuring a bunch of light switches in my office and door handles, bathroom sinks, toilet seat heights. And I think the door handle was like 42 inches, which is about 100 centimeters for, just over 100 centimeters. And that's important because sometimes if you can't reach that door handle, if you can't reach the sink to wash your hands after you go to the bathroom, shutting off lights, changing the temperature, that's all very important. And, it seems to me that probably the world is meant for around 144 centimeters. This is not a study that I've done. It's just in talking to my colleagues, that seems to be a height. So 4 feet 9 inches in the English system, or 144 centimeters in the metric system. On the right hand of my screen, I actually have average heights of people in Spain, because ALPE is a Spanish institution. And on the bottom left is the most recent data for people born in 1966 to 1976. And on the left is males and the right is females. So even if you look at where 144 in the female category, it's just at sort of the bottom 2.5% of the population. And then if you look at the male side, that's even lower. And so I don't think that lengthening patients with achondroplasia is a cosmetic procedure. I think and very much believe that lengthening patients who choose to be lengthened is really something functional to allow them to function more optimally in their society and in their surrounding environment. But again, I don't think anyone needs to be lengthened. It's a personal choice. So what is bone lengthening? This is an example of an external fixator. This is a device that goes on the outside of the body. We've made small incisions for each one of these pins to be inserted, and then a small incision to cut the bone, which you see here. And as I go through this is essentially every 2 weeks when we see this patient, we're lengthening their bone and you're seeing the new bone being grown until it gets to a certain length. This patient got about 6 centimeters. Now, this isn't how it always used to be. This is one of the first surgeons who started lengthening over 120 years ago. It was about the early 1900s. And what they would do is they'd put someone on a rack, they would cut the bone, and then they would stretch it all in one time, stretch it 2 centimeters, and then cast it quickly, which turned out to not be very successful. Over the years, it's been improved in Italy, in Germany, all with external devices. Finally, in Siberia with Gavril Elizarov, who came up with the circular fixator and really pushed limb lengthening to where it is today. And it made many improvements since the 50s and 60s to the current devices that we have now, circular frames that are assisted with computers. We still have monolateral frames, and then finally internal devices like nails. This is a patient with achondroplasia, and I'm going to talk to you about how I sort of evaluate this patient and what I think about in terms of treating them and what we can use, what device we use. So this patient came to us, they wanted to have limb lengthening. You can see above that his spine has already been fused because he did have some issues with spinal stenosis causing weakness in the legs, and we didn't want to take any chances when performing limb lengthening. First thing we do is we measure the bones. Can they fit a nail inside the bone? It is our preference to use nails inside the bone. And if we can't fit one, then we use external fixators or the frames outside of the bone. As I said the last webinar, if the surgeon that you're using is more comfortable using a frame, I think that's fine. I don't think one is better than the other. The point is you want to lengthen your bone safely. And so in their hands, if using a nail is safer than using a frame, then that's okay. And vice versa, if using a frame is safer than a nail for them, and they think they can accomplish your goals of getting that length, then that's okay too. This patient's bones were too small to accommodate nails. And additionally, he had some limb deformity in his legs, which frames are really helpful for correcting that deformity and obtaining length at the same time. You can see that this line is falling outside the middle of the knee. And so we chose to use external fixators to lengthen his legs. Now, depending on a patient's age, we will place all of these at the same time, or sometimes we'll stagger them by 2 weeks. So we would put on the frames on the tibias first, and then put the frames on the femurs 2 weeks later. It all depends, again, on the patient's age. If we use nails, we'll definitely separate those because that's a big hit on the body. Surgery is not something that should be taken lightly. It's safe to do surgery, but there's complications that can be associated with it. And so we want to make sure any patient that we lengthen is done in the safest manner. So then if you look at when he's done, he started out at about 333 centimeters or 331 millimeters, and we got him to about 436 millimeters, which is about 10 centimeters of lengthening, and probably the most common amount we do when we do both the femur and the tibia. The femur is the thigh bone, the tibia is your shin or lower leg bone. You can also see that with the frame, we're able to make it so that his axis is falling right down the center of the knee. So we're able to correct, he had knock knees before, and we were able to correct that to a straight leg after, and that's because we're able to use the frames to do this. Going forward, if you'd want another lengthening, we would likely recommend doing it with a nail, unless the patient requested that we do it with a frame, because we're comfortable with both devices. But the nail is usually tolerated a little bit better in patients. So the next patient, here are the preoperative X-rays, and actually this patient waited a little bit before going in to have surgery, so he grew a little bit and could accommodate nails in the femur. So these are the nails. These are put in through small incisions, one at the top of the buttock, and then 2 incisions to put these screws in, another incision to cut the bone, and then 2 more incisions to place these screws in to lock the nail. The nail goes through the bone. Bones are hollow tubes, and so they fit the nail. Sometimes the bones are too short, or sometimes they're too small to fit a nail, and again, that's when we would use a frame. You can correct some deformity, but you can also get some deformity with lengthening. And the tough part about lengthening with nails is if you get some deformity like knock knees, which here he was just on the outside of the center of the knee, and here he's just a little bit on the outside. This isn't a deformity that we would recommend correcting, but sometimes if this line falls even further outside, we have to take the patient back for a second procedure in which we correct that to make the leg straight. We also do things during surgery by putting extra screws in the tibia to prevent this deformity from occurring. Patients seem to like this more because there's nothing on the outside of their body, but it does take a little bit more expertise to lengthen with nails than it does with frames. In terms of pain, I think they're both, patients have pain after surgery with the application of a frame or the insertion of a nail, but during the lengthening phase, they're not that painful. Now, both examples I've shown have shown patients who've had all 4 extremities being lengthened at the same time. Sometimes patients choose just to have their femurs lengthened or just to have their tibias lengthened. And like I've said before, that's all a personal choice. The other difference between nails and frames, and I'm just going to go back a couple slides. Again, this is a frame. The last one were nails. Frames, we can walk on these devices while you're being lengthened. The nails that are currently approved for this use only allow 50 to 70 pounds of weight to go through them. And when you're doing all 4 limbs, you have to go by the smallest nail that you're using. So when we do nail lengthenings in all 4 extremities, a lot of these patients are actually using a wheelchair to get around. But when we use a frame, they can use walkers and crutches. So now we're back to the nails. Usually we do 5 centimeters in the femurs and 5 centimeters in the tibias. We lengthen at a rate of 3/4 of a millimeter per day in the femur and 1/2 a millimeter per day in the tibia. However, this can go up to 1 millimeter per day in either bone, depending on how good the bone that you're making looks. So for this patient, we would slow them down because we're not seeing great bone formation, versus if I go back to the frame, you can see this bone formation. You can see the bone that's healing and that's growing as we've lengthened. And this is really perfect bone growth where we would say, okay, let's continue at our rate of 0.75 or go up to 1 millimeter a day. I know this is a lot of information, a lot of numbers. You don't have to remember it because you can ask me more questions when I'm done talking about it. Lastly, and I just put these x-rays in to show how the bone healed. You can see the cortex or the outside of the bone after lengthening. Once you're done lengthening, you go into this process called healing or consolidation, which on average takes about a month. It takes about 30 days for every centimeter that you lengthened. So if you lengthen 5 centimeters, it could take 150 days to get your total healing done to go back to all your activities that you wanted. The other bone that we lengthen frequently, and actually I think is one of the most functional things that we do with limb lengthening, is the humerus. And again, you can use a frame on the outside of the bone like this, or you can use a nail. It depends on the inside of the bone. Here though, we do lengthen more. We usually get around 10 to 11 centimeters of length per lengthening with a frame. If you use a nail, you only get about 5, maximum 8, but it's usually 5 centimeters in the bone. And I think lengthening the arms is so beneficial in terms of taking care of yourself for hygiene, reaching things. I actually think it's really one of the most functional operations we do to help and with lengthening. Now, lengthening isn't without complications, and that's where in the past, I think lengthening's gotten sort of a bad reputation. It's hard because we see x-rays, and in x-rays we see bone, but what we don't see are muscles and blood vessels and nerves. And those are all the important structures that allow you to move and do everything you want to do. But we're also lengthening those as well. And so sometimes muscles get tight, sometimes nerves get tight, and that manifests as pain. And so we typically see patients every 1 to 2 weeks to ensure that their joints are still moving well and that we're not causing any damage. And if their joints start to get tight, if their muscles are starting to get tight, we slow down the process. So even though I say we lengthen, 3/4 of a millimeter a day, sometimes that changes. And that's because every patient is different. Other complications that can occur are limb or bone deformity. Sometimes, and actually commonly in patients with achondroplasia, we find that they heal too quickly, especially in children, and that's in the fibula, their smaller bone. Occasionally, we can see delayed healing. More so with frames than with nails, we can see a fracture because of the size of the pins that we use to control the bone while we're lengthening. And then joint stiffness, which is also like the muscles getting tight. The problems with muscles getting tight is they can cause you to subluxate or dislocate your joints, which is really a disaster outcome and something we try to, is actually the most important thing. It's why we stop patients from lengthening if we're worried about their joints, because a lot of patients will get fixated on, I need to get 5 centimeters. I need it. That's, and they're at 4.5 centimeters, which is 5 millimeters. And if you have a ruler in front of you, you should look at what 5 millimeters looks like. But we do not risk the joints of patients in order to get length, because the quality of life your quality of life will be reduced if your joint subluxates. And that's why it's important when considering these procedures or having them done, you're with someone who has experience in doing them. We also do a lot of physical therapy at the Paley Institute during lengthening. I can't speak for all surgeons, but when we have patients come here, they stay down in Florida for the duration of their lengthening, because if something is going on, if they start to lose motion, if they have a nerve problem, we want to ensure that it is taken care of in a timely fashion so that long-term complications are prevented. And so we do around 5 to 6 times a week physical therapy for 1 to 2 hours per day. Now, I have done some research on decreasing the amount of physical therapy, where we actually don't do any physical therapy, but have an extensive home exercise program, which proves to do pretty well when you're doing 1 bone, not when you're doing 4 bones. Additionally, and something I forgot to mention, is when we do both bones in the leg, we actually recommend decompressing the nerve, sort of like a carpal tunnel release you would do at your wrist. We recommend decompressing a nerve that's by the knee that helps with bringing your foot up and down, because that one can get tightened as you lengthen, and we want to try to prevent that from happening. If it would happen while lengthening, then that is one reason why we take, the patient back to the operating room to perform that release in the operating room. On the left, you can see some of our goals with physical therapy are really to maintain motion at the hips, at the knees, and at the ankle. If we're lengthening the humerus, we want to maintain motion at the elbow and at the wrist and at the shoulder. So take-home points, and really the most important one of all is it is up to you on whether you want to undergo limb lengthening. It is not up to your girlfriend or your boyfriend. It is not up to your spouse. It is up to you, because it is your body. I do think that lengthening can be functional. I absolutely do not think that lengthening in a patient with achondroplasia is a cosmetic procedure. It is one to help you with your life. And there are complications associated with lengthening. Surgeons need to be aware of that. Patients need to be aware with that. But it can be done safely when it's being watched. And, as a patient, you need to feel comfortable being like, hey, I'm worried about this. And you also need to be open to the doctor saying, hey, I'm worried about you. I want you to slow down on the amount of lengthening so that we can ensure that you get an optimal outcome. And that is it. I'm happy to take any questions that you might have.
Bueno, muchas gracias, Dr. Huser, como siempre, y es verdad que siempre nos gusta recalcar la importancia del lenguaje, ¿no? El lenguaje que sea siempre accesible a las personas que atienden a las charlas, ¿no? Porque realmente hay doctores que yo he visto en el panel de participantes. Es verdad que hay doctores que hacen y que trabajan habitualmente con displasias esqueléticas, pero sí que es verdad que hay un número importante de familias y de afectados, ¿no? Y entonces siempre somos bueno, siempre le damos mucha importancia a que el lenguaje de la charla sea accesible y que sea comprensible por todo el público que atiende a la charla. Yo creo que lo ha cumplido perfectamente, creo que ha sido una charla en la que ha hablado de los puntos más importantes que preocupan a las familias y con una terminología que realmente ha sido comprensible para todo el mundo, ¿no? Aún así, hay preguntas, hay dudas, entonces, bueno, me parece que siempre es un momento estupendo de intercambio de información y yo creo que siempre eso nos da, ¿no? Un punto extra a las charlas porque yo creo que realmente ampliamos la información de lo que es la propia charla, ¿no? Principal pregunta, ¿no? Partimos de la base que tiene que ser una decisión personal por parte del niño, porque siempre se suele elongar en una edad en la que son niños más que adultos, y en el que sea también interactuada con la familia. Entiendo. Creemos que, o cree que es importante una preparación previa a la elongación, no solo física, sino psicológica, ¿no? Cree que tiene que haber una preparación psicológica por parte de la familia en el sentido de saber a qué nos vamos a enfrentar en un proceso de elongación y en el que el médico, como usted, debe formar parte de esa información, de explicar realmente a qué se va a enfrentar ese niño y esa familia.
Yes, so I think it's two separate things. So psychologically, I think that's absolutely something to consider. I think it's definitely the responsibility of the surgeon to outline this is what you should expect over the course of this lengthening. You know, this is normal, this is abnormal in terms of how the body is responding to the lengthening. Most lengthenings, when you do them gently, and when I say gently, I mean that 0.75 millimeters a day, or if we want to just make it really easy, we'll say 1 millimeter a day, which would be extremely fast, in my opinion, to lengthen somebody. But that can be done in 4 different sessions, or sometimes 8 different sessions in a day. So each time you're only lengthening, you know, 1/4 of a millimeter or even 1/8 of a millimeter. And in doing that, there have been studies that show that your tissues really respond well and you don't have much pain. Pain to me, when patients have pain with lengthening, I get really nervous. And that's how I sort of prep patients for what they're undergoing or what they're about to experience. I think the other part, and I sort of touched on it, is a fixation on a number. I need to get 5 centimeters or I need to get 6 centimeters with this. The way we approach it is that we get 1 centimeter at a time by doing 1 millimeter at a time. And when we as a surgeon feel it's unsafe for you, we'll let you know. Now, in terms of the psychologic component, which I think is sort of like, why are you undergoing this? And asking that question, I think that's really important. I don't want to say less so, because I really think this is functional. We also do lengthenings that are cosmetic at our institute. I don't do those. I only do really the patients with skeletal dysplasias. But I think it's important on asking why you want to do this and just making sure, like, look, I think that will be helpful for me. And even if there are some self-esteem issues with it, I actually think that's okay too. Did that answer your question?
Entiendo que sí, o espero que sí.
Yeah.
Hay más preguntas sobre la edad idónea o adecuada para empezar este proceso de elongación. ¿Tiene usted una edad referencia o como referencia para poder hacer este proceso de elongación?
So I think between the ages of 10 and 14 doing one is fine. I do think that adolescence and puberty actually can make undergoing surgery like this more difficult for somebody. However, we also know that it is easier to lengthen people as they're younger, so under the age of 18 and 20, and really to have it all done before that patient goes on to university or college is ideal. And so going through, okay, you know, you're 10 years, making a life plan, you're 10 years old right now, this is the height you would ideally like to get to, this is how we can get there, and breaking that up so they have the most time in between surgeries and lengthening. 10 is sort of my lower limit, but you know, depending on how large the child's bones are, how mature the child appears, their ability to assent, which is the word we use for consenting when you can't legally consent. Those are all important. And that's part of the family too. Like, I would be hard pressed to lengthen a child with skeletal dysplasia so they have equal limbs who's 6 years old, you know, because I don't think they really understand the choice that they're making, and that's more of a parent's choice. In patients where one leg is longer than the other, that's a very different scenario where I'm okay with lengthening someone at that age because you want to have equal limbs, you know. But for patients with legs that are the same length but just short, I like to have them a little bit older, like say 10 or 11.
Sí, bueno, va un poco en la línea de lo que hablábamos al principio de la charla, ¿no? O sea, tanto que es un proceso de elección personal, la elongación, sí que creemos que tiene que haber una edad en la que ellos, los niños o las niñas, sean capaces de entender, ¿no?, a qué se van a someter y tener cierta madurez para prepararse y para comprender a lo que se enfrentan, ¿no? Entonces yo creo que ya no es solo un tema físico, ¿no?, de óseo, por decirlo de alguna manera, sino que también influye un tema madurativo, ¿no?, a nivel emocional y personal, ¿no? Yo creo que va un poco en esa línea por responder contigo la pregunta, ¿no? Hay que estar preparado, evidentemente físicamente, pero también mental y emocionalmente para este proceso. Entiendo que debe ser un poco así, ¿no? El dolor, preguntan también muchas familias en cuanto al dolor a la hora de elongar. ¿Es necesario en este proceso? ¿Se toman muchos analgésicos? ¿Es bueno? ¿Es malo? ¿Cómo atajar este problema del dolor durante la elongación?
So in terms of narcotics, which are opioids, like oxycodone, you know, what's been in the news a lot about the opioid epidemic that we have in the United States, and I don't know about other places. But really those strong pain medicines, we anticipate you should be off of them at 10 to 14 days. And that is only required for the initial surgery because we're cutting the skin, we're breaking the bone. But after that, when you're lengthening, it really shouldn't be painful. Muscles getting tight and tight muscles can cause pain. Nerves getting tight can cause pain. And if we notice any of those things, I like to slow down the lengthening, let the body catch up to what we're doing. So in general, the femur grows about, let's say, if we had to pick a number, about 14 millimeters a year. If we lengthen the femur 50 millimeters in 3 months, we've done 3 years of lengthening in 3 months' time, which is crazy to do on the body, but it can tolerate it if it's done right. Lengthening should not be a painful thing. The other thing I think about with pain, if we're using an external fixator, so that's the frame on the outside, is you could have an infection from one of your pin sites. If that's the case, we treat that with antibiotics. And sometimes I just had a patient the other day where I took him back to the operating room and just pulled a wire out because it kept getting infected. And that patient didn't require that wire anymore. The frame was still stable on how I constructed it. And so we just removed that wire. And hopefully that will take away that bothersome part of, her experience. So pain doesn't need to be part of lengthening. In fact, I would argue it shouldn't be, because lengthening is a long process. Acutely, yes, there will be some pain because you just had surgery. We just cut your skin with a knife. We just cut your bone. That's reasonable. But a week or 2 weeks after, you shouldn't have much pain. It should get better and better each day.
Bien. También están muy preocupados por el tema del patrón de la marcha. Se puede ver a veces que los niños que pasan por un proceso de elongación les cambia el patrón de la marcha, no caminan tan rígidos, no caminan tan derechos como antes de elongarse. ¿Qué se puede hacer previo, durante, después de ese proceso de elongación para que ese patrón de la marcha y esa manera de caminar y de moverse no varíe, no cambie?
So that's an excellent question. A lot of the things you have to, when you evaluate a patient. So when I see a patient for the first time, and I really didn't talk about this in my talk, so I'm glad you brought it up, is I do a full exam. I check out the tightness of their muscles. Can their hips totally extend? Meaning, can they stand up straight? Are their muscles loose right now? What's their range of motion like? When you do lengthening, like I said, we also lengthen the muscles, and you need to know when you're pushing that muscle too hard or too fast. You need to slow down, or sometimes you need to stop. That's also why we do physical therapy, and even physical therapy after done lengthening, to get your gait back. It is, no matter what your condition is, whether it's a skeletal dysplasia or a problem where one leg's longer than the other, whenever you lengthen anything, your body has to get used to it. If you've been living with a size legs for 10, 12, 15, 20 years, and you lengthen them, your muscles, your nerves, everything's going to change. And so there is a time where you have to continue to do physical therapy to sort of re-educate your body on walking. And it can take 6 to 12 months to get that re-education. And so for the patient you're referring to, I would really have to evaluate them and then probably do some physical therapy. And then if, based on my evaluation, I may also get X-rays to see, is there some bony deformity that occurred during the lengthening process? Or did they just tighten up across their hip because we're lengthening?
Tengo una pregunta aquí más técnica, en la que el término se lo voy a decir en inglés, por si acaso no hay una traducción exacta, ¿no?, al español, ¿no? Bueno, es de un doctor, nosotros lo conocemos, es un experto en displasias esqueléticas aquí en España, en Francia, bueno, en Europa, ¿no? Trabaja también muy cercano a la fundación, y pregunta que qué piensa sobre el alargamiento con Fitbone Nail. Fitbone Nail. No sé exactamente la traducción al inglés, por eso lo digo en español, en inglés exactamente la expresión.
So the devices that I showed you, I did not show a Fitbone nail. Absolutely, you can lengthen with Fitbone nail, but it really depends on the size of the patient in doing so. I think the Fitbone is a fine nail to use for lengthening. Recently, there's been a recall all throughout the world in one of the nails that we were using that allows patients to put their full weight through the nail. And I've actually suggested that we go to the Fitbone. You know, that nail before only allowed 2 people per country to use the nail when it was part of the German company. And so although we don't have much experience with it, one of my previous partners was a guy who used the fit bone nail and did use it frequently. And so I think the fit bone is a fine nail. It's a little bit different and can be a little finicky with the insertion because you have a remote device that you put underneath the skin, but otherwise it can lengthen just as well as any other nail. I hope that answered your question.
Sí, seguro que sí, doctor Huser. De todas formas, saben que cualquier duda que vayan teniendo, porque procesar la información a veces requiere de un tiempo, cualquier duda que vayan teniendo todos los asistentes al seminario pueden dejárnosla en nuestro correo de la Fundación Alpe, y nosotras se la hacemos llegar, como lo hemos hecho en la anterior charla, sin ningún tipo de problema, porque sabemos que usted está igual de disponible para dar la charla como para estar en contacto con nosotros para cualquier cuestión. Así que también entendemos que procesar información requiere también a veces de un tiempo, y puede ser que nos surjan dudas ahora, pero surjan dudas a lo largo de estos días y también se las haremos llegar, tanto por parte de las familias como de los profesionales, como ha sido esta pregunta. Preguntan también por el pie equino. Evitar el equino de pie durante el posoperatorio. Es verdad que es un tema que también nos preocupa en la fundación.
Foot drop, club foot after surgery. Yes, so on my PowerPoint, I had some splints that we put patients in when we're using frames. And so they just strap onto the frame and they keep the foot dorsiflex in that position, which also stretches your calf muscle. And the reason why your foot goes down or goes into equinus is because that muscle is being lengthened. If you're doing a tibial nail, some people recommend having the patient wear a cam walking boot, which is just a boot that holds your foot up in the neutral position so it doesn't get stuck going down. In order to avoid that, we would recommend physical therapy for stretching the gastroc daily, usually 3 times a day by the patient, and then also going to therapy to really work on strengthening the tibialis anterior muscle, in a muscle that may help with preventing the foot from dropping down. The other thing that can happen is you can stretch the nerve that affects the muscle to hold your foot up, and you can get something called foot drop, where you can't pull your foot up. And that's what I was talking about earlier when we do the thigh bone, the femur, and the shin bone, the tibia at the same time. We actually decompress. So we take the strangulation off the nerve, we release it so that the nerve is free and so that it doesn't get tight. Because if that nerve gets tight, your muscles can stop working, and then you can develop foot drop. You can develop an equinus contracture, which is a foot that's stuck pointing down. And obviously, that's not okay. That's not okay for that to happen. And that's why really one of the big takeaways I want to get through is that we surgeons care about you reaching your goals and reaching your length, but we also have to be guardians to the other parts of your body, like your joints. And we do not want to sacrifice your joints to get extra length. And that can be a tough thing for patients to go through. I want to get this length. We'll always help you get the length, but we do not want to sacrifice the other parts of your body, like your joints. So lastly, if you came in and you started with a foot that was dropped before, we actually may, and there's research about this in patients with achondroplasia, that they lengthen the tendon that behind your ankle, the Achilles tendon. And so that's been shown that you can lengthen the Achilles tendon to help with any foot drop that a patient may come in with. personally like to try to get that foot stretched out before lengthening, watch it. Some people will also, if they're using a frame, put the frame so it goes through the foot, which can be uncomfortable, but they can hold it up if there's a concern. So those are all different options to look at it. I like the patient to be limber and to have good motion before, because I know lengthening is going to affect their motion. And if they start with bad motion, it's only going to get worse. So I want them to have good motion, and sometimes doing some PT beforehand is helpful with that.
Bien. Hablan también de las secuelas, no a corto plazo, sino un poco a medio o largo plazo de la elongación. ¿Están estudiadas o ustedes han valorado dentro de su equipo estas secuelas o estas repercusiones de lo que es una elongación?
So that's an excellent question. And I think where it comes from is, what does it do to your joints? You know, with achondroplasia, and then with some of the other dysplasias like pseudoachondroplasia, diastrophic dysplasia, where the cartilage isn't nearly as good as it is in achondroplasia. We are putting pressure across your joints, near the hips, near the knees, and near the ankles. And the knees and the hips are the ones we worry about the most. I don't know of a study that looks at the natural history of comparing patients with achondroplasia to patients who have achondroplasia and were lengthened. And then is there a difference in, when they feel their joints are breaking down? I do think that we put force across the hip and across the knee joint that is not natural, because you're stretching these muscles, and you're just imagining these muscles are pulling back as you're stretching, they're pulling back and putting pressure across your hip joint and across your knee joint. And so that is something to consider. I don't have any evidence to support one way or the other, but I do think that it is a concern.
Hablan también de lo que es la infección de lo que es el hueso, ¿no? Hablan de que al haberse infectado las heridas, sobre todo las heridas, durante la elongación, por las fijaciones externas, entiendo, puede pasar que con el tiempo los que se han alargado tengan problemas de infección de hueso al haber tenido esas heridas infectadas por la fijación.
Yeah, so with an external fixator, the results of getting an infection during your lengthening is somewhere between 20 and 100%. And that sounds frightening. Most of the times it's something superficial where you can remove a pin and it goes away, or you just treat with antibiotics by mouth and you don't have to do anything. Rarely is it something where you have to go to the OR. The reason I went to the OR with the girl or the patient I was talking about before was because I tried to pull it out in the clinic and she didn't tolerate it. I said, all right, we'll just do a little bit of sedation. You don't need to be intubated, just a mask, and I'll pull it out so that you don't feel it. Now, on rare occasion, you can get a deep infection. That is one in the bone that's called osteomyelitis. The treatment for that is, again, antibiotics and sometimes removing that pin, and then that would be done in the operating room and we scrape it out, or removing everything completely and we put something like an antibiotic nail in. It's a cement nail that's just full of antibiotics that will sort of dissolve over time. Nails have less infections than external fixators because they're underneath your skin. External fixators are outside of your skin, so there's a place for the bacteria to go. There's technology to improve or decrease the pin site infections based upon some coatings on the wires or coatings on the pins. But that's really anecdotal. If you would get an infection that's deep within the bone, we can treat it, but we try to prevent it by watching for those superficial ones. It's very rare to have an infection deep in the bone without having one on your skin first and treating that with antibiotics. And that's where we try to cut it off before it gets too far. But then if you got one in the bone, I think that would be sort of it for your lengthening. Because again, I'm more concerned about your leg than I am concerned about getting you the length. Length is secondary to keeping your joints having good motion, which is part of the belief we have that if we can maintain good motion, then we're not going to put the forces aren't going to be as devastating to your cartilage. But yeah, it's really paramount that the length is our primary goal, but we're not going to sacrifice anything else to get the length, if that makes sense.
Que estaba silenciada, perdón. Una infección de un fijador externo es mejor o peor que una infección de un clavo intramedular, porque esa es otra de las preguntas. Dicen, bueno, es mejor un clavo, por dentro no se ven los fijadores externos, no evitamos verlo, evitamos, bueno, pues no tener complicaciones, pero en caso de infección, una infección dentro de lo que es un clavo sería peor que la de un fijador externo, hablando de infecciones.
Okay, so X-fixes are so external fixtures are attached to the body by pins, and then nails are the ones that go inside the bone that you don't see on the outside of the bone at all. I would say that a superficial pin site, that's just your skin, is not nearly as complex or complicated as one that's in your bone. And so if you did get an infection, and you can get infection, infection is always a risk with surgery. We try to minimize that. We don't see it that much, but you can get an infection in your skin, which again, you would treat with antibiotics. But anytime you get an infection in your bone, that is absolutely more serious. And it can happen from nails, and it can happen from external fixation pins as well. And we look out for that. And that, again, will cause pain, it will cause fevers, and that's how we recognize it. You can see sometimes on X-rays when you have your X-fix pins that they're loosening, and loosening can be from either improper insertion technique or from infection, which may lead us to say, okay, we got to remove this pin because we want to clear that infection. Once you remove the foreign body, which is the pin or the nail, it's fairly easy if you caught this soon enough to remove the infection, because you need blood to fight infection. Antibiotics carry blood, blood carries antibiotics. But metal doesn't have any bleeding. And so infections love metal, they love foreign objects because the body can't fight them. And so once you remove that foreign object, then the body can fight the infection with antibiotics and sometimes with surgery, depending how deep it is.
¿Tienen un protocolo de limpieza de los fijadores en vuestro Instituto Paley, en vuestro equipo, cuando pasan por ese proceso de elongación? ¿Tenéis un protocolo de con qué limpiarlo, de qué manera, cómo hacerlo? Ese tipo de fijadores, ya sean externos como los circulares en las tibias, o bueno, ¿tenéis algún tipo de protocolo a seguir?
Yeah, so I just have the patient shower once a day. And then wipe the sites clean. Otherwise don't touch them. That's sort of the way that I've been taught. That's the way most of us do it. We do have some families that use some other products that are very effective. They don't have any pin site infections. And it's this, there's a Russian mist spray that they use. It's great because it works, but for the most part, it is just shower daily. And then if there's any crud, just, wipe it off with a Q-tip, or any type of little bits of like scabs, just wipe it off with a Q-tip. Don't force anything. Don't go scraping at your pin sites. And that's what we do. Some other people use other protocols with hydrogen peroxide. or other solutions, but I don't think that's necessary. And sometimes I think it can hurt the skin.
O sea, una ducha de toda la vida, agua y jabón diario y está.
For a lot of things.
Fundamental.
Yeah.
Aparte de los fijadores, evidentemente. Una mamá nos dice, o una familia nos dice,
Yeah.
mira mis team, ¿puede ser? En el chat está.
Yes,
¿Puede ser ese
it.
pulverizador al
Yes.
que usted se refiere?
Yeah, that's the spray they use.
Ok. Pero sin ninguna complicación más, ¿verdad?
Yeah, that's it. They spray it on. Again, use a Q-tip.
¿Piensas que es importante una preparación a nivel físico previa a la elongación? En cuestión de fisioterapia, estiramiento del músculo, ejercicios concretos, específicos, antes de someterse a la elongación, preparar la musculatura y el cuerpo, aparte de la mente. ¿Crees que es importante hacerlo?
Yeah, I mean, you know, from the last talk I gave, I'm a pretty big advocate of physical fitness and stretching and just taking care of your body. And I do think that if you're a very tight person, that you should do stretching, you know, and try to fix that stuff before going forward with the lengthening, because it's not going to get better with lengthening. And there's a higher chance it's going to cause a problem that's going to prematurely halt the process from getting where you want to go. So again, it's all based on examination. To be honest, with most patients with achondroplasia that I've seen, they're fairly loose where they can get their knees straight, they can bend their knees, and I haven't really had that issue. But if that is something you're concerned about, number one, you should bring it up to your physician. Number two, they should, you know, examine you and find that that's a problem. And yeah, so that's it.
La elongación, no solo para condroplasia, preguntan, para otro tipo de displasias, por ejemplo el SEC. SEC es una displasia espondilometafisaria congénita, es una colagenopatía. Han realizado elongaciones en este tipo de displasias esqueléticas, aparte de lo que es la condroplasia. ¿Es recomendable, no recomendable? ¿Tiene mucho riesgo, poco riesgo? ¿Sabes algo o tienes experiencia sobre ello?
You know what? I actually have not. And the thing I'm concerned about.
SEC es lo que es el acrónimo de la displasia. No tiene experiencia sobre ella, ¿verdad?
Yeah, no, I know what SED is. I've seen the patients. I just haven't lengthened one of them. My concern is the same thing about their cartilage. I think they can be lengthened. I just think you have to watch their joints because there may be more instability that you're not seeing because the joints are so very different from what you're used to. And if there's joint instability due to how their bones formed, we do some other things, some preparatory surgery to make sure that they have stable joints. But again, with SED, with diastrophic dysplasia, you know, you worry about the cartilage and what it's going to do. So that's always in the forefront of my mind is, you know, not hurting the joints. But no, I haven't lengthened a patient with SED.
Y en vuestro instituto, en el Instituto Paley, lo que sí que vemos es que cuando hay una intervención de elongación, enseguida los pacientes cargan, quiero decir, se ponen de pie y empiezan a intentar, ¿no?, cargar su peso, porque muchas veces en otros procesos de elongación hay un periodo importante en el que están en silla de ruedas. ¿Es debido a que utilizan clavo? ¿Es debido a que hay un clavo específico que sí que permite esa carga en el paciente desde el primer momento? ¿Es debido a la rehabilitación que va acompañada a la elongación? ¿Nos puede aclarar un poco el proceso en concreto de vuestro instituto o de vuestra metodología?
So with the pins, depending on the bone size, we choose an appropriate pin. With external fixation, the frames that we use are pretty robust in that they can weight bear on them. We use between, again, it's either a 6 millimeter pin or a 4.5 millimeter pin. But those, usually 3 pins are fine for weight bearing and for the size of the patient. With the nails, it's a little different because they only accept between 50 and 70 pounds. And usually you can only use the smaller 8.5 millimeter nail, which only accepts about 50 pounds of weight bearing. The manufacturer recommends 20% weight bearing, but we'll do 50 pounds. And so those, sometimes we have patients, if you're doing both legs, you have them, because they can't just put 50 pounds on one leg, you have them then use a wheelchair. But with most external fixators, whether it's a monolateral fixator and we use a device called the drive rail, or the other device we use is just the circular frame by Smith & Nephew or by Orthopaedics, and those we allow them to weight bear on.
Y por aclarar un poco estas dudas que siempre llevan, ¿no?, a las familias que pasan por este proceso de elongación, en el momento en el que hay que corregir, ¿no?, que el hueso no está perfectamente alineado, recto, evidentemente el clavo ahí tiene menos funcionalidad, entendemos, ¿no? O sea, por ejemplo, las tibias siempre se acuden a fijadores circulares, o si hay fémures que no estén perfectamente rectos o alineados, tampoco a lo mejor es a veces posible, ¿no?, utilizar el clavo interno. ¿Es así? Bueno, por ir aclarando cuestiones.
Yeah, absolutely. So I actually have some strong thoughts on it. I think we can do really well with realignment with a frame. The problem or complaint is that you have multiple scars from the pins. When the pins are outside the skin, they drag through the skin. So you have scars and lines from those pins from where they started all the way down to where they finished. But if you want to correct deformity, a frame can lock it into exactly where you want to go. A nail, it takes a lot more planning. In the femur, we're pretty good with using a nail to correct deformity and lengthen. The tibia, we can look at our X-rays post-operatively. They look great. We think this is going to be a really good result. And we can still get some secondary deformity after that. And I think we aren't as good with a nail in correcting deformity as we are, and I'm talking about orthopedic surgeons in general, as we are with a frame. A frame has a higher tolerance for imperfection versus a nail. And it's really up to each individual surgeon on what they think their ability is to correct the deformity with the nail or with the pin. And no matter what they choose, so with a fixator, sometimes you have to go back and reprogram the fixator, not surgery, but just change the computer programming so you can correct the deformity. With a nail, if you don't like your correction, you have to go back to the operating room and just make some small adjustments to correct it. But it's all very, you can fix it. It's not the end of the world. Something can be done, but one does require another trip to the operating room, and the other one just requires some time changing the system around. But if you had
en cuanto a los brazos, que es verdad que siempre dan como menos complicaciones y es como mucho más fácil tanto la operación como el posoperatorio, pero siempre hay una pregunta en cuanto a la sensibilidad. A veces no hay pérdida de movilidad funcional, pero a veces hay pérdida de sensibilidad. ¿Qué se puede hacer ante eso? ¿Hay algún tipo de recuperación de esas complicaciones? O recuperación de masa muscular, porque también se ve que hay una pérdida de masa muscular con esta intervención.
So the big concern I have when I'm doing a humeral lengthening, so that's the upper arm, is the radial nerve, which comes from the back of the arm to the front of the arm, and it's near where we put the pins. So we have techniques where we just try to get away from that so it doesn't happen. If the nerve is affected, just like we loosen the nerve by the knee, we go up and we find the nerve and we loosen it by the elbow. Sometimes that nerve can be tensioned across a pin, so it's tight across the pin. Sometimes it can be wrapped around the pin, and so we just have to unwrap it. In terms of loss of muscle bulk, just whenever you lengthen a leg, the leg or arm will become skinnier because you're stretching all those muscles. The reason why arm lengthening is easier is because the muscles just aren't as big that go in the upper arm as they are on the legs. In terms of like real atrophy, meaning losing the muscle, I haven't seen that. And the radial nerve controls the ability to bring your wrist back like this or to give a thumbs up. And so that's one thing we're testing every time we see a patient in follow-up. Every 1 to 2 weeks, we watch them to see that they're maintaining that, because we don't want to stretch that nerve. And if we do, again, we slow down, we stop before there's a big problem where the nerve is totally gone.
Muy bien, yo creo que, bueno, tampoco quedan muchas más y tampoco queremos robarle mucho más tiempo, ¿no? Yo, por formular así como la última,
Okay.
para no aprovecharme mucho de usted, hay a veces que preocupa el pie, quiere decir, el pie no crece y el pie no se alarga y se alarga la extremidad. Esa descompensación, ¿cree que puede tener alguna complicación a la hora de ese posoperatorio, a la hora de ese patrón de la marcha, a la hora del futuro?
It's interesting. I mean, usually people are like, oh, can you lengthen my foot? And there's not really a good operation to lengthen the foot. But yeah, it's really a good thought in terms of how does your push off affect your gait when you've lengthened the legs, but maybe the proportions are different than your foot. I don't know. I don't know the answer, and I haven't even really considered that at all, but it's a really insightful question. I haven't seen a problem with it, so I don't think that it's something to worry about, but it's definitely, I'd have to think about it more.
No,
Thank you.
no sabemos si es un problema o no en cuestión. Nosotros vemos, bueno, usted sabe que en España hay un porcentaje elevado de niños y niñas con achondroplasia que pasan por procesos de elongación. Es verdad que es un país en el que está como bastante instaurado este proceso, ¿no? Y por nuestra organización pasan pues casi el 90% de los niños y de las familias que pasan por este proceso. Y sí que es verdad que es una cuestión que nosotros nos planteamos muchas veces cuando llegan a nuestra organización, que tenemos una clínica multidisciplinar, que hacemos este tipo de valoraciones. Siempre nos cabe esta duda, ¿no? Cuando vemos que a veces hay un patrón de la marcha que no está bien, no sabemos muy bien si es un problema de la cadera, si es un problema de la espalda, si es un problema psicomotor de insertar otra vez este esquema corporal en tu cerebro, si es un problema de que el pie está descompensado con la elongación de la extremidad a la que sujeta. Bueno, creemos que siempre es una pregunta importante a hacer a los cirujanos que trabajáis en este ámbito para que, bueno, si tenéis la oportunidad de estudiarlo, de verlo, de planteároslo, que si puede ser o no, si tiene algo que ver, si es una parte más aparte de otras, ¿no? Porque sí que creemos que puede ser importante a la hora de valorar muchas cosas, ¿no? O muchos factores.
Yeah, absolutely. I mean, I think about other conditions that I've treated where the foot is really short and I don't see problems like that. I would say that when you find these gait abnormalities, it's likely something to do with tightness across the hips, maybe the knees, maybe there's, going back to sort of the talk I had a month or two ago, are they having instability in their knees? Is there some sort of bony deformity that we're missing? Did something happen with one of their nerves where, the nerve is knocked out and that's why they're not able to bring their foot up or something like that? of course, I'm only looking at the problems I can solve too, not so much the ones that I don't have a solution for.
Bueno, bueno, pero ya sabes que nosotros siempre que tenemos la oportunidad de tener enfrente a un médico que trabaja y que tiene, ¿no?, en sus manos los niños y las niñas con acondroplasia tardías esqueléticas, aprovechamos la oportunidad para, bueno, ahí lo dejamos. Dar que pensar, dar que reflexionar, porque eso siempre es importante, ¿no?, a todos los niveles.
Keep them coming, keep them coming.
Es perfecto. Bueno, no queremos perder o hacerle perder más tiempo, ni robarle más tiempo, que ya es suficiente todo el tiempo que nos ha dedicado. Insisto, si hay algún tipo de cuestión que nos haya quedado, que le haya quedado a cualquiera de los asistentes a este seminario, nos lo pueden hacer llegar a través de nuestro correo y nosotros directamente pues le mandamos un email con todas estas preguntas que sabemos que, bueno, que siempre está encantado de poder contestárnosla. Yo creo que solamente queda una que yo creo que es más burocrático que otra cosa, ¿no? Que es en el caso de que quisieran ponerse en contacto con vuestro instituto, con vuestro centro, porque puede ser que en un futuro la niña pueda pasar por este periodo de elongación, ¿qué deben de hacer? Email, teléfono, contacto, no sé, alguna...
Yeah, they're more. So first of all, they're always more than welcome to email me at my email address. And then what I do is we forward it on to our admins who will get in contact with them and set anything up. You know, COVID has been devastating to everybody, but it has opened up this ability to do webinars and Zoom conferences. And I think we've all gotten used to doing that now. And so for those patients who are overseas, we are always open to have that first discussion through a medium like Zoom or like this webinar to discuss, you know, what they're thinking, what they're looking for, how can we help them, to do sort of a rudimentary exam to see that, you know, everything is okay, and then review their X-rays. They can send their X-rays here where we can review them and then go from there. I can give you our number.
Estás todavía compartiendo pantalla, doctor. Sin nada, pero compartiendo pantalla.
Should I stop sharing?
Ahora.
Sorry. Okay, let's see here.
No hay problema.
So yeah, so do you want me, so the number that, so they can email me, which is fine, and I can forward anything to the people that need it. But the phone number that we have, it's a US phone number, so that's country code 1. And then the phone number is 561-844-2555. Sorry, I got to start over. I said it wrong.
Bueno, lo podemos apuntar en el chat.
You want me to put it in the chat?
¿El chat en la pantalla? Perfecto.
Okay, that's the right number. That's the right number.
Genial. Bueno, pues muchísimas gracias de nuevo. Reiterar todo el agradecimiento, todo el cariño del mundo desde España, desde nuestra organización. Es un verdadero placer tener a profesionales como usted tan cercanos y tan disponibles, no solo para nuestra organización, sino para todos los asistentes a este seminario, que, bueno, pues que vienen de todas las partes del mundo. Y bueno, confiamos en volver a tenerlo, seguro, ya que bueno, pues que lo tenemos tan cerca y tan disponible, seguro que volvemos a solicitarle su ayuda. Le invitamos a participar en nuestro próximo Congreso Internacional el próximo año, en el 2022, confiando en que todo esto vuelva a la normalidad y que pueda venir a España a nuestro Congreso Internacional para, bueno, pues para seguir divulgando todo ese conocimiento y toda esa experiencia que tiene. Y le deseamos un feliz fin de semana, una feliz primavera y confiamos en tenerlo muy cerca muy pronto. ¿De acuerdo?
Thank you. Bye.
Muchísimas gracias. Un beso muy grande desde España.